Hey, this is Dr. Joe Tonti with Building a Healthier Edmonton podcast. Today, I had the opportunity of speaking with Dr. Jerome Fryer. I thought we had a fantastic conversation. Dr. Fryer is a chiropractor out in Nanaimo, BC. He treats a lot of individuals with a multitude of musculoskeletal problems. Today, we spoke about the spine primarily. Dr. Fryer talks about different strategies that you can do to help offload the disc, because we know the disc is one of the primary causes of back pain for a wide majority of people. So he talks about different strategies, how we can slowly decompress the disc, reducing that disc height loss. We talk about specifically for individuals with stenosis, that's narrowing in the spine, how they're able to do that. Also for individuals with disc injuries, younger people typically have a disc bulge or a disc herniation, some strategies that they can use to help heal that disc and take pressure off that disc so they can have much less back pain coming from those areas. Dr. Fryer also has an awesome spine model in his office, a couple of vertebrae from blue whale. Actually, he kind of shows us that at the end. He has a lovely office, wonderful person. This was a fantastic interview. I hope you enjoyed today's interview with Dr. Jerome Fryer. Here we go. Hi, welcome to the Building a Healthier Edmonton podcast. I'm with Dr. Jerome Fryer. He's a chiropractor out in Nanaimo. He runs Dynamic Chiropractic Clinic, and he's also operating Dynamic Disc Design, which is it builds models of different areas of the body. Good afternoon. Yes.
Good afternoon to you.
Well, Dr. Fryer, so tell me about, you're obviously a chiropractor, so tell me a little bit why you got into chiropractic in the first place.
I wanted to get into chiropractic because, I had a sports background and I wanted to help people regarding their injuries, and I wanted to make an impact. Plus, I had to kind of get going. I was wandering around in UBC and thinking, what am I going to do with my life here? So I didn't want to live at home any longer. So I had to get going. So I had to choose a career, and I chose chiropractic because it was natural. I like the natural kind of theme behind chiropractic. Pharma is a big animal, and I thought, I didn't want to be biased with my education, so I could bring the best and the most natural therapeutics to my patients. And yeah, I just basically chose, it was either going to be an environmental lawyer, help the planet, or I was going to help the people, and it was like a toss up. So, okay, away we go. And it's been 22 years now.
Oh, I see. Well, I'm glad you didn't turn to the dark side there. No offense to any lawyers listening. That's great. You went to healthcare.
Got to use the force.
Yeah, absolutely. So you have a lot of experience, obviously, dealing with people with a lot of back problems, a lot of musculoskeletal pain. Tell us a little bit about like how you work in your clinic. There's a bunch of different chiropractors, they do different things. So how is your kind of style of practice?
There's not a bunch of different chiropractors. I'm the only one in this one clinic. So I just focused attention on patient education and arriving at an appropriate specific as I could possibly be for diagnosis. And then I just map out a therapeutic plan for that specific person, and everybody brings in their own little package of injuries and stress and right. So you have to be adaptable to each case. But around 2007, I started a research career too. And I started pushing with some research ideas I had. And a lot of the themes that came out of that research paper that was published in 2010 had to do with offloading. So often when we know there's a common theme with back pain. And it's, if you look at, the full population who has back pain, one of the most common themes is that you will find disc height loss. You will very likely, most probable, is that the disc in these people have lost some height. Okay. Some of them have lost quite a bit of height at a particular motion segment. Sometimes a disc height is lost here and the one above is moving too much, for example. If you've got disc height loss, for example, at this one, well, the one above, because this is stiffened, now the one above is moving more. So the theme that I have, that I constantly work on is keeping people tall, keeping disc heights as tall as they can be, minimizing the compressive loads over time. Like, for example, I was part of this study recently that was published in the Journal of Ergonomics, and just sitting here, you and I are losing height. Our discs are slowly compressing. And when a disc has lost its ability to maintain its own height, it loses its height quicker. So, for example, with my patients, they'll be leaning on the armrest, and I got the other hand kind of on their leg, and I can tell already this is very likely a compressive issue because they're naturally offloading with their arms to slow down the compression in their spine. And I saw this with using upright MRI in Scotland, where we used an MRI is normally horizontal, but most people have symptoms when they're vertical, whether they're standing, whether they're sitting, first thing in the morning. So I went to Scotland and used the first ever upright MRI, and I was invited to this clinic, and we were measuring disc height changes, angular changes. You remember those books that you'd flip through and it would be kind of animated, but each page would have a different sort of scene. So if you go, the character would move, right? Well, we looked at 30 seconds. This is as tight as we can get it with the MRI, 30-second images, every 30 seconds, images of the discs. And I could see them they were moving. So my theme in my clinic, for the most part, on the therapeutic side of it, is balancing out the motion between each vertebrae and giving them strategies throughout the day to offload or to keep their tires pumped up.
Okay. I'm curious with that MRI, couple questions here. Why do you think, or why aren't standing MRIs more like readily done? And let's start with that question, because that seems so obvious, because most people they have the problems when they are, like you said, when they're standing, when they're upright.
I think the problem was in the execution of the technology. So all radiologists conventionally are trained with 1.5 Tesla magnet. So basically think of that like a megapixel camera. For example, I'll use 10 megapixels, right? So all radiologists that are trained, they're used to looking at 10 megapixel images. So they can zoom in, zoom out, zoom in, zoom out. So they've got all these pixels, right?
Right.
And then you go to the 3 Tesla, which is like some radiologists don't even like looking at it because there's so much detail that they don't even know. They have a hard time it's too much detail for them.
Right.
Interestingly. Okay. So, but their standard is 1.5, but the upright MRI is 0.6. So what happened was when this got to market, the radiologist would take these images and they go, this is only 0.6. I'm not reading this. This is only 0.6. I'm not reading this. But they're not looking at the bigger picture of the motion and the load, the disc height changes.
Right.
I was actually I was a lead author on this paper, and the anchor author was Dr. Francis Smith, who actually pioneered the upright MRI. He was the one that I gave this presentation to. So he told me the story about why there hasn't been much of an uptake. It's interesting.
Okay, so it has to do with, that makes sense. So if you're not used to seeing a certain image in a certain clarity, I suppose you could say you just wouldn't be used to reading it. So it'd be kind of like not as detailed, or so they just didn't do it.
Yeah, exactly. They were like, there's not enough information here, and this is a poor quality study,
right.
They would think necessarily, right? So they would just dismiss it. So that was kind of That's kind of how it it didn't get sort of integrated. But there's still research facilities. If you look at the research, you look at, when you bend the spine backwards, right? The disc will bulge into the canal, pushing on the nerves, and you bend forward and the annulus will come tight. It comes tight and it comes off, or the ligament folds on itself. So there are aspects, and we know this with patients. We know this, that patients have pain when they walk for whatever. It could be to their mailbox, or it could take them 10 kilometers. There is something going on that's different in there. And the models that I've created take that dynamic component into the equation, even if it's millimeters. When you are fractions of a millimeter of a rootlet, matters a lot.
Yeah, that'd be make a huge impact on someone, even just slight movements. I see that. Well, obviously we both see that in practice. I'm curious, with these MRI studies, were they looking at disc heights in like a healthy population where they didn't have any pain, or are these in symptomatic people?
Which studies are you talking about?
So the one you mentioned where you had the functional, or the MRI did the 30-second intervals, and you.
That was our study. So that's when I went to Scotland and we took who we could get. We actually went in the hospital, and we actually recruited nurses that had a break. And so for the most part, they were asymptomatic. And I didn't screen out previous back pain or anything like that. I was getting who I could, because it was kind of it's a pioneering study. Nobody had done that before, right? So it was to get some baselines around it.
Okay, yeah, that makes sense. And for anyone who's not familiar with the research, it's a long, grueling process. And sometimes, especially when you're dealing with people, you need to get whoever you can get. I remember I did some research back in like my undergrad, and it just takes way longer to do, and it's grueling, basically.
It's grueling, process. And when it's self-funded too. This was something that I pulled out of my own pocket to make this move, because I was just excited about the idea that I had developed with this offloading exercise. So I was like, I don't care, let's go. Let's make this happen. So that too, right?
So some common issues with this offloading, it could be with a lot of people with back problems, as you mentioned, that loss of disc height, but it's especially prevalent with people that as they get older, someone who may have some narrowing in there, some stenosis, or if you're having a disc herniation, say a chronic disc bulge. And then, as you mentioned, you're able to walk a certain distance, and then those symptoms gradually start building up, or they gradually start coming on, either back pain, and sometimes you can start getting that radiation into the legs, that sciatic pain. What are some strategies that you find useful for patients that are dealing with this kind of problem?
Okay, let me just go get something. I'll be right back. I'll shift for a demonstration purpose here.
So if you're just listening to this, Dr. Fryer, he has some models that he's kind of illustrating. So you may want to check out the video if.
So you described the patient that has stenosis.
Yes.
Right. So quickly, I just pulled the nerves out of the canal. Here's the spinal canal. And you can see how open it is, right? Lots of room, right? Lots of room for this guy. And there are the nerves that go into your legs, these guys here. So this canal needs to remain open.
Yeah.
But you can see down here, there's actually a disc that's kind of bulging back a little bit. And if you can see that, right? Mm-hmm. Right. So it actually can take up a little bit of space. And then when you compress it, it takes up a little bit more space. So over time, what happens is this is a relatively young spine because it's got good disc height. But over time, this will lose its height and you can develop into this, which is where the disc flattens. Right. And then there's osteoarthritis of the facet joints here. But importantly, if you look down the canal, right, you look down the canal and you see a very tight canal. And if you put a pen up this one, okay, it's actually kind of stiff. right? So you asked me what sort of strategies are going to be helpful for people with this. I'm getting to it, right? But for me, part of my clinic and what I do here is I empower people with understanding what it is they have so they can start making their own decisions about which exercises would be helpful. Yeah, really make their own, to start making educated decisions. So this, for example, that's the front, right? This is the back. When people walk, the spine goes into extension a little bit and it compresses a little further, and you can see that this gets tighter. It actually narrows the space. So, but what do these people typically do, Joseph, when they have symptoms? What do they like to do? They
Yeah,
go
sit
for
down.
okay.
Well,
So what does sit down look like?
yeah, so
Sit
it
down looks
flexes
like
the,
flexes. Okay, so let's flex this, and now look at that, and look how much it didn't take much. I just flexed it like 2 degrees, and look at that. Now it's opened up. So that's why people can walk a certain distance. It starts to encroach on the nerves, and then they sit into flexion, right? But remember, when you sit in flexion, you're compressing your disc again, right? So you're kind of not, you're you're giving yourself some symptomatic relief, but are you targeting the main issue, which is the disc height loss? Not
right,
tons, right? It depends on how bad your stenosis is, right?
right.
So do you think that maybe doing something, on all fours? Let's see if I can do this. I'm not going to be able to do this, but you get on all fours, like a quadruped.
Right.
Now you're offloaded. The disc is not under compression because you're in a horizontal state,
Right.
right? I've got my hands on the ground here, right? And
Yeah.
then I'm more in a horizontal state. Then go into flexion, probably better, right?
Okay. Yeah. Because then you're
Right?
decompressing that disc as well as flexing the spinal canal, make more room. Okay. That makes a lot of sense.
Yeah.
Okay, great. And how about someone with, it would be like a similar situation as well. So those stenotic people, as they're typically, in their 60s and older. And then a lot of times people, if they're younger, they may have like a disc herniation, and they actually find movement can be helpful. But if they move too much, they, things get sore again. Would you have like a similar strategy for this kind of population?
Well, it's kind of difficult because
I know it's
everybody's
hard to
pretty
say.
unique. Hey, I know
Yeah.
it's difficult to do that without a proper assessment. I was talking in
Yes.
generalities, and so keep your readers
Yes.
keep in mind that make sure you have a specific assessment and specific diagnosis before doing any of these exercises, right? But do you have a central canal stenosis, or is it a lateral stenosis where the nerve root is being pinched on the outside? And for example, you talked about the younger population, right? So why does the younger population more likely to get a disc herniation? Well, what is a disc herniation? Well, that is when you have a more pliable, juicy, so to speak, disc that actually is more maneuverable. And it has a nucleus, which is in the middle, and an annulus. They're actually two distinct tissues. When you get this old, it becomes kind of one homogeneous kind of tissue. The nucleus kind of melds into the annulus and it becomes one kind of tissue. Here you have a distinct different. So when you bend forward, remember that, when some people would walk a certain distance and they'd feel better in flexion, but with these people, if they have this type of an injury where they have an annular fissure, which is like a little tear on the inside, bending forward will actually spread open that fissure and cause the nucleus to push posteriorly, like it'll actually come back, right? So that's not so good. I had a recent case, and there's certain, you hope that people are listening, right, when you talk and when you try to educate. The models help a lot, And I had a case. I haven't seen this guy too often. His back flares up. Maybe see him once a year or something, right? But he had done something to his back, and he was trying to stretch it out. He was a young guy, and he was like determined to stretch it out.
Yeah.
Yeah, blew his disc right out, right?
Yeah.
And I thought, did I fail with my education? I don't think so. I just think that he wasn't listening and paying attention, and it's really unfortunate because when he came in, I was like, I took that to heart. I'm like, you're a patient of mine and that happened?
Right.
That's just, you should know better,
Yeah.
So it's so understanding, what it is very, very important, and I think now I heard that he's like lined up for surgery, and he doesn't even need surgery, but he got kind of whisked away by that world, right?
Right.
And so anyways, so you got to be mindful, right? You got to
Yeah.
figure out, you got to go to somebody like Joseph to, figure out specifically what's going on before you start implementing a proper strategy, right? So in this case, if someone comes in and they go, I check their range of motion and I say, okay, bend forward, and they go like this. And I can see on their face, like, ooh, it hurts. And then they go, like they're going to show me their range of motion.
Yeah.
You've seen that.
I don't know why people do that. I'm not impressed with how far you can go. I just want to see how you respond. So I don't know why people do that, but they do.
Well, because we've always prided ourselves on flexibility, and you got to, historically is like, can you touch your toes? Okay, you're good to go. You're in the army. You know what I mean?
Yeah.
So there's history there, but it's all about the quality of motion that I'm more interested in. And, so for example, if someone comes in and they have symptoms in flexion, what I'll do is okay, that's good. You're not here to show off and show me how much you got here, right? And then we'll check extension, and if they have good extension, well, guess what? We're going to be doing offloading exercises and extension to approximate and to pull those two tissues together. There's a little fissure. It's kind of like a cut in the skin, and you want to, like, if it's really cut, guess what you got to do? You got to go get stitches. The spine is very similar. It likes to approximate so those fibrocytes can kind of hang on and try to mend, right? But if you keep opening it up, right? And then it becomes granulation tissue there, and it becomes chronically inflamed, and nerves start to grow in, which I've demonstrated in here. So yeah, I could go on and on and on, but I better.
Yeah, I think the basic understanding here is you got to know what's causing the problems so you can treat it and do the strategies on your own most appropriately, and not just because it feels like a tight muscle. Don't just stretch it, because oftentimes people will have disc problems and you just have back pain, and quote unquote just have back pain, and you try to stretch it and you'll be like, oh, that's such a good stretch because I feel it. But like, if it's a disc problem, like you're making it a lot worse. I remember I was listening in on a presentation with Dr. William Morgan, Parker University president, and he was talking about a patient who they had a disc injury, they had an MRI, he had a disc injury, and he started doing some rehab with a different person, and they were trying to flex him because they're like, oh, you can't bend forward, so we want to make you bend forward, which was the wrong thing to do. And it just made this person have just exactly as you described, that disc didn't heal. It got those nerve infiltration into the disc, and then it was chronically inflamed, and he has just persistent pain now. What would you say? Is there anything else that you'd like to mention today? We talked a lot about trying to maintain that disc height. Is there any strategies that you have? Generic, obviously we talked about being specific, but different things people can do to try to maintain the health of their discs, either nutritionally or exercise wise or otherwise.
This is going to be this is my little secret.
Oh, okay.
So don't tell anybody, okay? This one was actually when I went to Scotland, and I was a young researcher, and I was very excited about my protocol that I put together. So I had subjects sitting on a stadiometer, and I measured their height, right? And then I got them to sit there for 15 minutes. And then I measured their height again and went down. And then I got them to do the exercise, right? 5 times 5 seconds. And their height went beyond the initial height. And I was so excited. And then their height after 7 minutes started to come down again. And I was so excited with the stadiometer because I was going to go. I went to Scotland to measure it with MRI, and I said, okay, now the subject needs to go into the MRI now. And Francis Smith, your reference to Star Wars in the beginning, he's the Yoda of spine. He said, Jerome, you must lay the subject down for 10 minutes in order to neutralize the disc height. And I was like, that's even more interesting than my exercise. So guess what I encourage? I encourage people to take 5 to 10 minute naps throughout the day to replenish the disc height. Simple, 5 to 10. If you look at the cycle, the diurnal cycle in disc height, it's within the first of 5 to 10 minutes that you get the greatest return on that disc height. So when you're, at lunch, if you're like sitting and eating, well, I guess you don't want to lay down and eat, but if you're resting, if you're sitting watching TV or you're watching your phone or something, guess what? Get recumbent. Get recumbent for 5 to 10 minutes. You're not being lazy. Nothing's going to get weak on you. You actually increase the disc height significantly. And then it's like recharging your phone. Just away you go again. Okay. That to me I've helped countless people by telling them to take a nap.
Right.
Seriously. Yeah. And you don't need to fall asleep. You just need to get, right?
Just lay down for 5 to 10 minutes.
Yeah.
Okay. I think I'm going to have a lot of employers kind of coming at me wondering why they need to get all these cots at work. That's a great idea. Great. Well, thank you for sharing that. Anything else you'd like to mention to our listeners today? Anything that I didn't fail to ask you today?
I don't think so.
Okay, great. Well, what's the best way for people to get a hold of you if they're out in Nanaimo, if they know someone out in BC, or if they're curious about your models or any of the research that you're doing?
Yeah, so my chiropractor website is drfryer.ca, and my dynamic disc designs, which is the spine models, is dynamicdiscdesigns.com. And I have some other websites that'll direct you to my research and all the testimonials from all over the world. Now these are being shipped all over the world because people are starting to really take notice on on the posture and the mechanics that really matter.
Yeah, your models are awesome. I have one at the office here. I got to get a couple more, but yeah, they really help kind of illustrate, provide patients with that education so they know what's happening. These are much better than the crappy plastic ones. I mean the plastic ones that you see otherwise, because it actually has like a functional model to it, so you can see how everything actually changes dynamically.
So I got one. You asked me if there's anything that I wanted to share. This. Anybody know what that is? That is a blue whale spine. Those are actual real vertebrae of a blue whale that were donated to me by a fisherman when I worked on the West Coast in Tofino and Ucluelet. And I strung them up. There's 11 of 56. So it's right beside my cabinet where I display my models to give people a proper scale comparison. So when they walk into the treatment room, yeah, that's suspended above them.
That's pretty cool. I wonder what my colleagues here, they treat animals as well. I'm wondering how they'd be able to adjust the beluga's spine. That'd be interesting.
I think it's impossible.
Yeah. all the soft tissue, right?
Yeah.
Cool. Well, thanks again, Dr. Fryer. And if anyone's interested in what you're doing, definitely reach out to him. He's a wealth of knowledge. So everyone, thank you for watching or listening, and we'll talk to you next time.